You're 82-year-old woman with a normal lumbar spine, and by the way, degenerative arthritic disease makes those T-scores fall asleep good. And when you see a T-score at the lumbar spine of +2, that's from degenerative arthritic change. We look at the hip, she's minus 2.1 T-score. Does she have osteoporosis? She's osteopenic. So what do? We go to FRAX, plug her in. She's 82. That alone is going to push up her 10-year risk. We don't even need FRAX to realize with that T-score and her age, she needs treatment. Case number 2, you're 76-year-old. She has type 2 diabetes. Look at her right and left hip scores. Her left femoral neck, -3 and -4. And these are real patients from my practice. What do you think about this patient? Does she need a workup for secondary cause? She's only 76. Look at how bad, how low her T-scores are. And look at her change. She hadn't had a bone density for about 7 years, lost a lot of bone. 2.5% is significant for loss from one bone density to the other in a relatively short time. So what do? And look at her plugged in. And you see that with secondary osteoporosis changed to yes because of her diabetes. And here you see, what would you do with this patient? You got to think sequencing. The best use of anabolic bone building therapy is to do it first, followed by maintenance with an anti-resorptive. And here's your, and here is a 76-year-old. This is my real patient. Totally normal hip scores and a form of -3.7. No hyperparathyroidism. I did, she has already had 2 infusions of zoledronic acid. What would you do? It's only a forearm, but it is a forearm. But we decided to do a 3rd IV infusion. And the last one I'll tell you, this is a real patient of mine, 80-year-old, tiny woman, 4'8", 100 pounds, came to me new. She told me she had taken a pill for osteoporosis for years. Then she went on denosumab. After 7 years on the drug, she got a blistering skin rash. So 2 different dermatologists got biopsied. It was nonspecific, but they told her, stop the denosumab, which she did. She came to me and hadn't had any medication for 2 years, and these were her scores. A -3.4 at the hip. She was a fracture waiting to happen. She had lost significant bone from the previous. So what would you do with her? And what did I do with her? Who would give her an anabolic agent? Who would refer her to endocrinology to get an anabolic agent? Well, she's a perfect patient. So I think she was my first one. I prescribed myself. Kind of nervous. I actually, my look-up-to person is one of the leading researchers in the country, Dr. McClung out of Oregon. I happened to see him at meetings and pick his brain, and he came to do a dinner program in my community. And I said, Dr. McClung, I think I should prescribe anabolics. He said, you should. I said, well, I think I'm ready. But it was his support, and he said, email me anytime. And because of that, I felt ready, and I started her on romosozumab. And she got 10 months in and called me that she had a rash. So I said she didn't want to take anymore. And I said, it's up to you. You've had 10 months of bone building. And we couldn't use denosumab, so we put her on an oral anti-resorptive agent. So there it is. So screen and treat, determine your level of comfort in what you prescribe. There's a lot out there to help you become more confident.